The next case is 72-year elderly male Kandaswamy, diagnosed to have IT fracture left side, posted for close reduction with DHS, which is done under segmental epidural.
We are going live with Dr. Silamban. Dr. Silamban, sir, you're on.
Yeah, thank you so much. A very good morning to all of you. I just like to play a few slides of PowerPoint before I go into this. Basically, segmental epidural, the idea is to place the catheter very ideally according to the surgery and to use a very, very minimal amount of local anesthetic as is possible. So, the basic principles of segmental epidural is what I'd like to tell you. Next slide. Next slide, please. Yes. First, you do not decide where you are going to poke the patient. First, decide about the area to be blocked. It depends from surgery to surgery. For a case of DHS, it is ideal and more enough if you block from T12 to L4. For example, you're opening the abdomen, you should block from T4 to T12. Suppose you're doing a breast and segmental epidural, ideally you block from C6 to T6. So first you decide about the area to be blocked. Then you decide where you are going to place the tip of the catheter. Ideally, the tip of the catheter should be placed at the center of the areas to be blocked, taking into consideration that local anesthetic spreads equally on both sides of the catheter tip. Next slide. Next you decide about the length of the catheter you are going to place inside. Ideally it should be only between 3 to 5 centimeters. If more than 5 centimeters are kept inside, coiling, knitting, knotting, doubling of the catheter, passage of the catheter in the intervertebral foramina can all occur. And if it is less than 3 centimeters, accidental catheter exit in the postoperative and intraoperative period is also a possibility. So once you decided the length of the catheter to be between 3 and 5 centimeters, then you decide the site of needle entry. The site of needle entry should be 2 vertebral spines below if you are having a capillary threading of the catheter, or 2 segments above if you are having a caudal threading of the catheter from the tip, taking into consideration that the average, roughly average distance to cross one segment requires 2 centimeters of the catheter to be threaded inside. Next slide, please. So next, finally, we decide on the volume of the drug. Lumbar space being the widest space among the epidural space, ideally 2 ml per segment is what is preferred. But in elderly, obese and short stature, the volume can be reduced by 0.5 ml per segment. When you come to the thoracic level, it is about 1.5 ml per segment, and the cervic level is least with 1.25 ml per segment. This being a case, we are going to have it at 2 ml per segment. This being a 72-year-old man, we are further going to reduce the volume. Next slide. So what are the agent and regimen preferred? The first dose is always preferred, Xylocaine 2% adrenaline. It is not only preferred for its rapid onset of action, but also for the intense blockade and better relaxation of the muscles which it gives when compared to a 0.5% bupivacaine. The second dose, I would prefer to give half of the first dose, preferably to intensify the blockade. And third and subsequent doses, if required, can be with Xylocaine with adrenaline if there is no tachyphylaxis, or can be changed to 0.5% bupivacaine, and it should be 1/3 of the first dose, but the minimum volume of 4 ml is a must. Next slide. The duration between doses, because we are going to go segmental, there is only one segment above the surgery site which is anesthetized. So there is rapid regression of the anesthetized segments. So 2% Xylocaine with adrenaline will ideally be repeated every 45 minutes. 0.5% bupivacaine can be repeated every 90 minutes. Next slide. So for example, this dynamic hip screw fixation, you apply these principles of this segmental epidural here. So segments to be blocked are from T12 to L4. So catheter tip, like I said, is placed in the center, that is L2, between L1 and L2. And then the length of the catheter inside we plan is at 4 centimeters. So needle entry will have to be at L3, L4, and the volume of drug is going to be 9.5 ml at 2 ml per level. But because this is an elderly man, we are going to use only 7 ml of local anesthetic here. Next slide. Next slide. Yes. So here, this is a reversal of the catheter, where you also go from above downwards in case because of pain or something like that, patient does not flex properly. The same principles you appear, but you enter from above and thread the catheter below, keeping the tip at L2 as usual. And the volume is the same. Yes, next slide. Thank you very much. Now I'll go to the demonstration. Yes. இங்க வந்துருங்க, இந்த முதுகு காட்டிருங்க. Step up, live. Yes, you see I marked it here, L4, 5, this is the area L4, T12 to L4 is what we are going to block. So I'm going to place the catheter tip L2, so I'm going to make an entry at L3, L4 and thread the catheter in by 3 centimeters so that the catheter tip is roughly around T2, L2. This principles is what you will have to understand. The epidural technique is all what you use, nothing special about it. I am feeling the phlegm now. Yes, we are through. Sir, मेदो मूछ भी दौड़ूंगा sir. The catheter is also being threaded comfortably. See 1, 2, 3, 4, 4.5, 5.5, 6.5. We have got this space at 3.5 centimeters. We are going to place the catheter in by about 3 to 4 centimeters. So at 6.5 or 7 centimeters, we fix the catheter at the skin level. (15, 20). 9, 8, 7. So we fixed it at 7 centimeters now. Roughly say about 3 to 3.5 centimeters from here to L2. So catheter's rough tip is exactly at the level of L2. And we assume that drug is going to spread equally on either sides of the catheter tip. This may not be very useful in very young people, but in very elderly people with low ejection fractions where you do not want hemodynamic imbalance, the segmental epidural becomes a very important tool because only these areas are going to be blocked. So there's not going to be much hypertension at all. We are going to use 7 ml. In very sick people, we even use 6 ml and we finish these surgeries. Fix the catheter.
Do you have any queries to Dr. Silamban?
Yeah, yes sir, please, if you have any queries, please ask me. I'm almost finished.
Hello.
Yes?
I'm continuing from the previous case about fixing of the catheter.
Yes.
You use that locket device which is available for fixing the catheter?
Sir, I usually use, on my regular basis, I use only a Vigon epidural needle and catheter which is 9 centimeters with a polyurethane catheter. So that does not have any fixing device. I do not use any other epidural needle in regular anesthesia practice. So I am not able to understand what you are telling of the locking device. I am not exposed to that.
There is a device like a ECG lead,
Okay.
and a small locking at the back.
Okay.
Introduce the catheter through that small device which is there inside,
Okay.
and then lock over it so that the catheter doesn't move from the insertion side.
See, what I do is, even when I fix up a catheter, the same tagadam without the plastic, I try to fix. I try to fix the catheter more closely to the skin, like this, so that it does not exit. Suppose what I personally feel is, suppose you have this type of gauze here, this is what is going to give the tensile strength to fix the catheter. Here the catheter is going to be loose only because it is not fixed to the skin at this level. So there is a possibility that this gauze becomes loose, the catheter can accidentally exit. I use the tagadam without gauze and fix it directly to the skin here and then put in a plaster to fix the catheter. That is how I fix it regularly.
Okay.
I prefer a Vigon needle because they have these polyurethane catheters which are very, very, very soft when compared to these catheters. Thereby, the chances of inadvertent arterial puncture or venous puncture is very much reduced. These catheters are much stiffer. So actually sometimes there is a plexus of veins or something like that. So when you try to maneuver it, it pokes the vein and it starts bleeding into the catheter. Whereas this is not seen in Vigon catheters which are made of polyurethane. So I generally prefer to use polyurethane catheters.
Sir, in thoracic epidurals,
Yes?
any tips for success?
Pardon me?
Thoracic epidural.
Yes?
Is there this thing on thoracic later?
Pardon me sir, is there a?
Is there a for thoracic epidural?
I don't understand. I don't get it.
Thoracic level, sir.
Yes, there is no live demonstration at thoracic level, sir. But there is a talk with a video at about 2 p.m. about epidural for laparotomies where that will be shown.
Okay, sir.
Any other queries from the crowd?
Sir, hello.
Yes, madam.
What was the ejection fraction in this patient?
This is a normal patient, madam.
Acha, but
This is
then
this
you
is-
just wanted to show segmental epidural, that's why you gave this, or can we give a spinal for DHS in the lower segment?
Madam, it is all your choice. Choice of anesthesia is entirely yours. The problem is, if ever you give a epidural catheter, you can always give continuous post-operative pain relief, which is useful.
Okay.
This was demonstrated for segmental epidural only.
Okay, thank you, sir.